I'm Lucy Gunning. I'm a pediatric occupational therapist, and I have been, doing this for a really long time. I have worked in the school systems for over 25 years. I have also worked as a dysphagia specialist or feeding and swallowing specialist in a clinic setting. And I am a certified assistive technology specialist as well. And, you know, I have worked with kids with Down syndrome from 0 to 21 for over 20 years. So I've seen the gamut. But today I'm going to more talk about, I'm thinking the population that's more needed here is babies and the newborns that maybe come in. So I'm going to stick to that a little bit, but if you have questions about anything else, just let me know. First thing I'm going to talk about, and you did get a little bit of this probably earlier, but those anatomical features that we see in kids with Down syndrome, but how they affect feeding. The first two things are the smaller oral cavity, as well as that relative macroglossia. So we call that relative because, and I don't know if you talked about it this morning, but a lot of people think that kids with Down syndrome, their tongues are larger. And really what we see is that the oral cavity is smaller, which makes the tongue look larger. So that's why we call it relative. It's not a true macroglossia. We see a lot of tongue protrusion, and that's due to that reduced oral space, which also can give us limited control. And then in older kids, you'll see that Gothic palate or that high narrow arch in the palate, and that is usually not from birth. You don't see that as much, but we see it in kids who are older, most likely from the way the mouth sits or the tongue sits and kind of increases that arch as they get older. Some other comorbid conditions that can affect feeding. So just your digestion and absorption issues, like celiac. Cardiac considerations, we have a high population that have some cardiac issues. And, you know, you're just like all your cardiac kids, you're going to see the same types of things that you see with feeding. Constipation is a big one in this population. Obviously respiratory, and that other thing is reflux. And I see a lot of kids who do have reflux. And I just want to highlight some of those things as far as the reflux that you might be able to observe when you're seeing the child in the clinic or in the hospital. The main things here I think that you're going to really notice are the arching of the neck and the back during or after feeding. The obviously unexplainable crying or irritability. We know there's something going on. Reflux might be one of those things. The frequent night waking, so maybe for those older kids, those older babies, you know, we know our newborns wake up frequently overnight. But if you're seeing somebody who sleeps and then they wake up frequently crying at other times when, you know, they shouldn't be hungry, this might be reflux. There might be some reflux going on there. And then just that fighting during feeding. You'll see kids who are, you know, they're turning their head, they're pushing away, they're squirming, they are showing you, they're fighting you during feeding. Okay, I'm going to talk a little bit about the research on the prevalence of feeding issues in Down syndrome. And we got some pretty high numbers here. First of all, the main reason for referrals for a swallow study, a video fluoroscopic swallow study, is clinical signs and symptoms during feeding. And I think, you know, as nurses, you guys are the first ones who are seeing this and getting a look at how the feedings are going. So I think that's important for you to be aware of, because you are the ones who are going to be making those referrals and noticing those things. 96% of infants with clinical feeding issues had some manifestation of dysphagia. So out of these kids that they did the study, they did the swallow studies on, 96% actually had some type of dysphagia. And that's a pretty high number. And then I just want you to be aware that those kids that you're seeing who are desatting with feeds and have airway and respiratory anomalies, we know that these kids are just definitely at a much higher risk. So kids we need to keep an eye on. So 69% of those kids who actually had the study, they had dysphagia severe enough to warrant alteration of their feedings. So they either were taken off of foods and said, okay, no more oral feeds, and had to go to like an NG tube or possibly, depending on severity, go to a G tube, a G button. And then one of the most frequent, as far as the alteration of consistency, one of the most frequent treatments is the thickened liquids. And then followed by a system change. We'll talk about that in a little bit. So a little more research of those who had feeding issues, 63 to 90% had oral motor difficulties. So the oral motor difficulties is that oral phase of eating. So that is the manipulating food with their tongue, the chewing phase. So that's the stuff that's going on in the mouth. The oral sensory difficulties, over 20%, but this is probably much higher, but we notice this a little bit more in older kids. So you might see an older kid who won't advance with feedings because they have hypersensitivity in their mouth. So they might not advance to different textures. Those kids who have hyposensitivity or lower sensitivity, those are the kids who really can't feel where the food is. These are our stuffers. If you see a kid who's a stuffer, they often need to get a whole bunch of food in that mouth before they are aware of what's in there and where it's at before they can manipulate it. So we see that with our stuffers as well. And then this is another scary part, is 68 to 72% had pharyngeal phase dysphagia. So that is that deep laryngeal penetration, pharyngeal residue, the delayed swallow initiation, and those are all the things that put the kids much higher risk for aspiration. And this is the thing that we really want to be careful of. And then, this is the worst one of all. Of those who aspirated, over 90% were silent aspirators. And again, this is all research with Down syndrome. These are kids with Down syndrome. They were not showing us any of those clinical signs. And I'm going to show you a recommendation here soon. But I think it's really important to know that, just know from the start that these kids are predisposed to aspiration. And just quickly, some of those possible signs of aspiration that you will and might notice, and again would want to refer them on or get some more information on. The coughing or choking during or after eating, hoarseness or gurgly voice, so if you're listening to if you're feeding a child and then they start cooing or making noises or talking if they're older and their voice is gurgly, that stuff's hanging around back there. And anything that hangs around back there is at risk for going down. Slight fever after feedings, wheezing and breathing problems, frequent respiratory illnesses, fussy eating, weight loss, definitely, maybe some of our failure to thrive kids early on. And then food coming out the nose. So that is that nasal regurgitation or that nasal reflux. That in the back you have that uvula, and there's a purpose for that, because when your swallow is initiated, that pops up and it covers the nasal area so that food doesn't go up through the nose, it goes down into the esophagus. And if we have some issues with the swallow, the initiation, you're going to see a lot of it coming out their nose. That just tells us something, those mechanisms just aren't really working right. So this is why the AAP has come out and said that, you know, with this population, with kids with Down syndrome, you absolutely should refer for a swallow study anyone who has marked hypotonia, which is pretty much most of our kids with Down syndrome, slow feedings, choking with feeds, recurrent pneumonia, other recurrent or persistent respiratory systems, and then unexplained failure to thrive. So this is the recommendation pretty much for every baby with Down syndrome. And again, that came out in 2011, but was reaffirmed in 2018. So this is still pretty current. And I just wanted to throw in apparent experiences of feeding problems. The most occurring problem, 0 to 3, that parents indicated was that the infant tires quickly before feeds. They saw a lot of the problems with the suck, the weak seal, choking, coughing, vomiting, difficulty with the suck, swallow, breathe sequence, and then they had trouble with positioning. But the thing that I really wanted to notice that, or bring out, was that 70% of the participants had said that they received support from a nurse. And I think this is actually much higher, because again, you're the first ones who are getting to see them and getting to observe those feeds. So I think your role is extremely important. So low tone, again, we know there's a high prevalence of low tone with Down syndrome. And this can contribute to a lot of things with our little ones. So you have to remember that the tongue is just as much a muscle as any other muscle. And so it's going to react like any other muscle that has low tone or has decreased strength. So this can contribute to decreased endurance for feeding, poor tongue and jaw strength and mobility, decreased coordination. We'll often see a poor latch and weak sucking, uncoordinated swallow, which again puts them at risk, the poor lip closure and seal. And when you have that poor lip closure and seal, you're going to see a lot of that, a lot of the formula coming out the sides. And then that tongue protrusion. And I really see the tongue protrusion a lot when kids are transitioning from a fluid, a liquid, to a puree. So I just think it's important that, you know, I think when a parent gives birth to a child with Down syndrome, whether they knew or they didn't know that this child had Down syndrome, there's just a whole lot of questions. I know a whole lot of people think, oh, I'll never be able to nurse this baby. I heard, you know, kids with Down syndrome, you can't nurse them. And that's not the case. So just to know what the advantages are for this population, these are advantages in general for breastfeeding, but these are really important for this population because there's that lower risk of malocclusion, so that that mandible maxilla, the using that jaw appropriately and having those things lined up. It promotes normal mouth and tongue coordination, and we already know that our kids with Down syndrome have some difficulties with that tongue coordination. Obviously, not the nursing part, but the breast milk itself has that improved immunity to virus and infections, and our kids have a high rate of infections and may reduce bowel problems like constipation that we see a lot. Known to promote brain growth and development. Obviously, we know there are some cognitive issues associated with this population. So that's important as well. And then just strengthens the baby's jaw and facial muscles. And this lays that good foundation for feeding, obviously, but for that future speech and language. You know, we always tell parents when we're feeding, we don't like kids to stay on a bottle for a long time, because when you're using a bottle, that nipple, it encourages that forward-backward motion with your tongue. That is the first primary movement that comes in developmentally. And if you continue to use that bottle, they can get stuck in that forward and backward motion. And that's a more immature pattern. So we want them to be able to get to the point where they can do some up and down movement with their tongues, which starts to come in when you're doing purees. And then that lateral movement of the tongue, which comes in when we start to manipulate food for chewing. But I think the important thing is that we want to make sure that we move them through those stages for the long run. I've heard a lot of parents who have said, you know, well, I just don't think I'm going to be able to breastfeed, to nurse my baby with Down syndrome. And there's really no evidence that babies with Down syndrome feed better from a bottle. So there's no research that shows that anywhere. What you're really going to want to do is advise parents that feeding problems improve substantially by 3 to 4 months. So we know the research shows that even though these kids have some early difficulties, that usually by 3 to 4 months, they're usually on track, and they can usually get past that. Also be aware of that low muscle tone is going to have difficulty with latch at first. So again, be aware of these things so you can share this with your parents. Some of these things they need to know. Also need to know that these babies are often sleepier than other infants, so they may need a lot more alerting in order to stay awake. And then, of course, there's surgical and medical conditions that come. So a lot of our babies can't start out with normal feeds, and so that's a factor that you're going to have to deal with the family as well. And then we know that it's easier for a child to latch on and feed and get that nutrition if mom has plenty of milk to give. So just know that during times of psychosocial stress, that a lot of women will have a delay of their milk coming in. And so I think it's important, and I might repeat myself later, but I think it's important that we make sure that parents they're trying, if they're not successful with the breastfeeding immediately, make sure that they're still pumping, they're expressing the milk, so that they can continue to get their flow going. Okay, so I think just some of the things, you know, what can you do as a nurse with a child and a parent with Down syndrome. Definitely educate the parents on the importance of breastfeeding for children with Down syndrome, just both physically as well as just the benefits of breast milk in general. And like I was just talking about, support the moms to reach and maintain a sufficient milk supply. So make sure they are constantly still expressing. Encourage that kangaroo care because, well, a couple things. It's easier to arouse the child for feeds if they're right there with you. More opportunities to attempt feeds. So, you know, if the mom has difficulties, you know, trying getting the child to latch or whatever it might be, they're right there with them, and so mom can try it again at any time. So you increase those opportunities, and then just, you know, it really encourages that eye contact and touch to assist with the bonding. So again, when you have a child with Down syndrome, whether you knew or not, bonding is a really, really important thing for us to encourage between the mom and the baby. And of course, refer to the lactation consultant or a feeding specialist if you're noticing any issues with the feeds. Make sure to assess the ability to latch, suck, and transfer milk, and then reassess frequently. So reassess how the baby's doing as often as you can with feeds, just so you have an idea. So what can you do? One of the main things you want to do is provide good head and body support. You want to use that sling or pillow to support the child in that flexed position. Because if you've ever seen a really low-tone child, you know, most of our babies are all nice and flexed up, and those low-tone babies, gravity just pulls them right down, pulls them right out. So we want to really center that child and get them back into that flexion mode. Trying out the dancer hand position while they're nursing, if you can teach this to the parent. It allows the mother to support the breast as well as the child's chin. So the thumb and the index give gentle pressure to that masseter muscle to help stabilize the jaw, because again, with that low tone and that decreased strength, you know, those little mouths are just kind of going all over the place. Plus, you can give some of that stimulation to that TMJ to help those muscles fire, you know, to get them kind of locked up and ready to go. Not locked up, you don't want to lock them up. Pull the jaw slightly forward may allow the infant to better grasp and form a seal. And you see the pictures here for that. And then definitely, if you're really concerned, and I know a lot of moms are concerned, how much is my baby getting? Is my baby getting enough from when I'm nursing them? So you just might have to do some weighing, some test weighing. You know, diaper off, sensitive scale, before and after the feed. And just find out how much. And that's important for the baby, but it's also very important for the parent to really feel comfortable about, okay, I am feeding my baby. They're getting enough from me. And again, consistent milk expression. Make sure that she's producing enough so that the baby is getting enough. And again, that psychosocial support, I think that is so important at that early phase, to really be able to let the parents know, you know what, this might be a little hard, but you can do it. Let's keep trying. Let's try some of these things, and don't give up. Any questions about anything?
I don't have any questions, but I think just what you said,
Right.
That feels overwhelming. That alone can make a huge difference.
Yeah, exactly. For bottle feeding with an infant, again, try both. I just always like the bottle feeding too, because of course we want the breast milk in the bottle, but it is such a great time for a family member, for a father, to be able to do that feed too, to be able to do that bonding as well. And I think that if a child is, one of the things that I find often with babies with Down syndrome is once you do just breastfeeding and you just nurse, and that's all they do for the first few months, and this is especially important for moms who go back to work at a certain time, that these babies will not transition to a bottle. And I have worked with numerous babies who are like, and I can only imagine the stress that it is on the mom who has to leave her baby at daycare and her child won't eat unless she nurses. I know so many mothers who actually go to the daycare. They take off, they go to the daycare a couple times a day, and they nurse, and then they go back to work. So, for some reason, I just see it a lot. So I think it is really important to bring in that bottle early and then keep it going, because I think once you get past that point, because that initial suck is reflexive. But I think once you get past that point with that reflexive suck that helps them to transition between the two, I think you kind of lose it at some point. And I think that's what makes it harder for some of our babies. So just keep that in mind, be aware of that. If you can, get them doing both. Not just for that social and that bonding, but for just long term when you can't be there to nurse every time.
Can I ask a question?
Sure.
Do you think, so you mentioned like the coordination with the tongue
Uh-huh.
can be like a big challenge with feeding?
Right.
And the tongue action is different when you're breastfeeding versus when you're bottle feeding as far as like controlling milk flow?
Yeah.
Do you think, we see that with just any baby.
Right.
Goes between breast and bottle.
Right.
Is that part of the challenge for like this population too, just because it is more challenging, they're already dealing with that coordination?
Yes, absolutely. Yes, absolutely. And we do need to work through that, but that's why I say try to do that early when that reflexive tongue movement is in place, because then they kind of have an advantage of learning it. I think that if you wait too long, then them being able to transition from the one to the other makes it harder. So, of course, you want them, their arms forward and in midline, because we want the tongue is the thing doing the movement, that midline. So, again, we don't want them hanging out here. We want them all kind of pulled in, nice and flexed. So the swaddling helps the baby to really have that body awareness of where their body is, but it also keeps their body calm. Gives their tongue the chance to do the work, be the muscle that's doing the work rather than this stuff. And then just that tactile and proprioceptive input from being swaddled, is very calming to the child and to the system. So a couple of good things about that. So one thing that you can do with this is that external jaw support. So you saw back here with the nursing, that support the mom gives. But when you're doing a bottle, it's a little bit different. And I should have brought a bottle with me. Maybe I'll bring my matcha tea. I know it's not pretty looking, but so a lot of times I can work with a child and have the bottle just resting kind of in my web space here in that spot. And I can take my middle finger, I don't know if you can see this or not, take my middle finger and get it under the chin, and then I can take my index and my thumb and get it right on that TMJ up there. And so I can stabilize that, give input there, as well as help control the mouth a little bit with the chin. And you're not pushing the chin up. That's not the point. You're helping them stabilize it so that they aren't, with that low tone and in coordination, we just see a lot of those really wide mouth excursions that, you know, kind of all over the place. And the wider they're going, the more movement, the more work they have to do. So we're just kind of, okay, here's a good spot. Let's just keep you there and not let you go past that. Oh, sure. You've got a baby. Of course you do. It's hard with having this bottle in, but so my fingers, so the middle finger right under the chin. Can you get that? And then these, and they're, you know, and our babies are small enough that we can get our fingers right up there on that joint. Or if we need to help with that suction, I can also go just on those buckle on the cheeks right there on those pads, and I can push in a little bit too and help them to secure that, you know, that suck in with the cheeks. So, and again, the bottle's sitting on, it's just resting here. And I'm not going to be able to do it with this because it's not the right. But, so yeah, just some of that support. And again, we're not pushing into them. We're not pushing up. We're not trying to move them into a certain position. We're blocking. We're blocking instead. So up here and then down here. And of course, they're all swaddled up and nice and close.
How long age-wise would you continue to have parents swaddle them, you know, for feeding or and to provide that support?
Yeah, it depends on the child. Okay. I mean, if you start to see, we want the child obviously to eventually start to be able to control that themselves and get that skill. So as the baby starts to do more on their own, that's when you start to back off. You know, swaddling I think will take a little bit longer just because of the tone and the, but again, it's going to depend on the baby too and what they need. If when you let them go and they get all dysregulated and start doing all this and you want them focused on here, then you need to wrap them up again. You need to swaddle them again. So just some basic feeding resources. The websites to go on to are always helpful and always give more good information. Just feeding in general, this New Visions, I think is it's a great, if you just want to learn about feeding in general, they just have a lot of great articles in there. Feeding.com's another one, and then there's some just feeding books out there. So that's, I thought we might have time for questions.
Okay, so as a pediatrician, I refer to early intervention right away.
Uh-huh.
And like once they're referred, a month of age or whatever, how quickly do you get involved with these patients? How quickly do they get that first assessment?
Immediately.
Okay.
You know, we have timelines of when you get the referral, you need to make the contact within, and I think it's 7 days or something. But we need to get in there right away, and then we try to start our evaluation. And oftentimes with our little ones with Down syndrome, and this is my district, and this is what I do, but one of the first things we do as far as assessment is feeding. And we go in and look at the feeding because often that's the first thing. Because you're not really seeing motor delays yet. You're not seeing language delays, that sort of thing. So oftentimes that's the first thing I'll do is I'll go in and I'll assess the feeding and see where they're at. And
so if the child is
do.
But if there are red flags and you feel like they need a fluoroscopic study, do you contact the doctor? You tell the family to contact the doctor?
Absolutely,
Okay.
yeah,
Yeah.
yeah. That would, if I'm seeing any of those issues, that's the first thing I would go to, especially with this population where we know that they are at risk, at pretty high risk too, for aspiration and feeding difficulties. So, and a lot of times that's already even begun before they get to me. And so sometimes they even come in with those swallow studies done, which is great to have that. And then I know, okay, what direction can we go? Because certainly we won't work on oral feeds if we've been told that they're aspirating. You know, you have to approach it obviously in a different way. So, so yeah, that's one of the first things we do is request medical records and find that stuff out.
What typical thickeners are you using for thickening?
Just like the thicket, that sort of thing, yeah. And I know there's lots of kind of controversy about that and what's in that, but you know, some people will do the rice cereal, some people will just something to thicken it up a little bit, yeah. Yeah.
You can keep it if you want to. Mention how early, and Dr. Nelson kind of touched a little bit on it, but I guess I was surprised, and some people might not realize being in the school system, this isn't school-age children. Obviously, this is your same early.
This is 0 to 3.
Are they coming to you? Are you going to the home? How does that
No, we go to the home.
Okay.
Yeah, we go into the home. Well, okay, COVID kept us, pre-COVID, COVID kept us out in the spring, but now we do go back into the home if it's okay with the parents. We have a whole list of protocols that we need to follow in order to go in. We send the text before we go with all the questions, and then of course we mask, and everybody else needs to be masked, and so yeah.
Is there kind of a routine, like a general guideline for how many times you see it, like how often you see a family once they're referred to you? You know, you have the initial assessment. Is there, or is it just fully individualized based?
It's definitely individualized, depending on what the needs are at that time. How much support does the family need? How much support does the child need? And a lot of times, and again, I can only speak for my district, but a lot of times we put on our IFSPs a range of, you know, like we'll see them this many times in 6 months. So it might be that in the beginning I need to go in and I need to do weekly, you know, and look at their feeding and get them started on that, and then back off for a little bit and kind of see how they're doing, and then go back in, and then maybe at that time it might be motor that we need to work on a little bit. So it truly is individualized and depends on the child's needs.
And so is that kind of the progression that you mentioned, eating is in your first?
And not always,
Okay.
but often. I mean, often it just is.
Your eating, motor, language, is that kind of like a typical progression?
Yeah, I mean, because language is not just, and this is why we bring our teachers in immediately, because we know there's going to be cognitive delays, and so much of early language is not articulation. It's not where you put your tongue to say, you know, it's all about learning that when I do this, this happens. When I cry this certain cry, Mom feeds me. When I, you know, so it's all about communication rather than language early on. And that's what our teachers are beautifully set up to do, is work with that early communication. But that happens from the start, you know, learning the cries and figuring that stuff out, yeah. But yeah, feeding usually is one of those main things we see an issue with from the beginning with the little ones.
And then how typically, when would you say, like on average, that feeding is kind of, they become more independent, you're not having to, that's not kind of your focus when you're meeting with the families? Is it, I mean, by 6 months, would you, earlier than that?
Well, and to know that the research shows that by 3 to 4 months, usually kids they've got the feeding down. But that's often the time then that mom's getting ready to go back to work, and we're having some issues with now transitioning to a bottle, you know, 6 months, whatever the parent decides to transition to the purees, and that's a whole nother set of feeding issues. And you're transitioning to the cut, you know, and so I've just learned that our kids with Down syndrome always learn to do these things. It just takes a little different method. There's just little different tricks I use with this population than I use with others that I see consistently because of those oral motor things and the cognitive things and the so yeah.
That's good. And then what about like transitioning to solids?
Mhm.
Is that typically like, is it later? Does it take a little bit longer for them? Like, are you starting that at a different?
And again, it's individualized too. It really is, because I do have some kids who don't have those issues, and yet other kids do. But I always say, you know, if they're ready, if you're seeing that, so and it's those tongue things I was talking about earlier. If I'm seeing some of this movement go on, I know that they're able to more effectively get that puree on their tongue and move it back efficiently for swallowing. If I see a kid who has absolutely no lateral tongue movement, then solids are not the thing. But again, they kind of need that experience to learn. They need some solids to learn to move it back and forth as well. So that's why I go towards those dissolvable solids. You know, the yogurt bites, the little puffs, the things that I know that they're going to get in there, they're going to feel that solid, but it's going to melt before it gets scary. But yeah, I want to see not only can they, if I put it in their mouth, can they take it with their tongue and move it over to the sides for some munching. It's not chewing, they don't have teeth yet, but munching. And then also, once it's over there, can they take their tongue and hold it there in that spot so that they can keep the food between their teeth to munch too. So there's a whole lot of stuff going on in your mouth that that they need to learn that's going to make it safe for them to eat. And still a lot of kids, and again, we have that tongue and oral cavity difference, and I see a lot of kids who just smash everything up at the top. And so we really have to move them out of that, and there's just kind of a series of things to do for that.
It just seems like it's a slower progression if they have an NG tube because of heart surgery.
Absolutely.
Maybe quite a bit older, it seems like by the time they're...
Absolutely. Then they've lost those reflexive things, and you know, that we hold on to that reflex. Yes, we need that for a while. But yeah, absolutely. And then they just have it's just harder in general. So that's why we want to get in there and get it going good right away and get those transitions going so that we don't lose our opportunity.
Don't you recommend even if they have an NG tube that you're still doing some oral
Oh,
stimulation?
sure, absolutely, yeah, yeah. But then the NG tube has those sensory issues. It has, yeah. I mean, there's all something, you know. But that's the way it is. We have to work through it, and it's always all about making it positive. And that's why I put reflux up there pretty high, because kids learn really quick that as soon as I put this in my mouth, I hurt. And I am not going to do that. And that's when you get that fighting, and they just learn, I am not going to do that anymore. It hurts. So, yeah.
Did you touch on pacifier use at all? Is this population, because a lot of times we'll say, you know, in the hospital, like the AAP says, if you're breastfeeding, not to introduce a pacifier until breastfeeding is well established. But there are medical indications for using it. So like with our preterm population, a lot of times that's helpful just to coordinate that suffocating and
Exactly.
swallowing and breathing.
Yeah.
Would this be similar with the Down syndrome?
Yeah, absolutely. And even just to use as oral motor exercises. And also, if you know, that would be one of the things that I would do with an NG baby or a button baby, you know, is to keep that connection as well. That, you know, that you're sucking and your tummy's getting full. That's what we want, you know. This is how it is. So when I start putting a bottle in there and your, you know, NG's out, so you want to keep that association going too. Yeah. Great questions.